But welcome everybody. I'm Richard Taylor, a retired hospital physician for rather a lot of years, who had the huge privilege of being an independent MP from 2001 to 2010. And the marvellous thing about being an independent MP is that you can vote with the government when they're right and vote with the opposition when they're right. Absolutely wonderful and the greatest fun. And marvellous to know that the select committee system works without whips. So select committees do work on what's right for people, whereas every other committee has a whip there and they can't do what they really ought to and would like to do. Anyway, Ian Gibson, a retired medical academic, was the president of Leukaemia CARE for many years. When he retired, I took over, and it's absolutely marvellous being the president of something, because you don't have to do any work. Everybody else does all the work, and you just stand there and talk occasionally. And Leukaemia CARE is an absolutely amazing, splendid, unique charity, working not on research, as so many other charities are working, but on actually consideration for the patient and care for the patient. And the support telephone lines that are always open, and people who've got these nasty diseases want to talk to somebody, and time again they don't like to talk to their family and their relatives. So even in the middle of the night they can pick up the phone and talk to somebody. So that is a marvellous service for the patients. But as well as that, I think one of the huge functions of Leukaemia CARE is trying to keep doctors and nurses informed with what's going on. And you've no doubt seen the marvellous Spot Leukaemia 10 symptoms. And any doctor should have at the top of their awareness the basic symptoms of cancer, weight loss, change of bowel habit, cough that goes on, just a few obvious things that make you think of cancer. And the same, I think we've got somewhere stuck up the 10 points that make you think of leukemia. And if only all GPs would bear these absolutely simple, straightforward things really in mind, then we would improve our diagnostic rate. And you can't make adequate, correct treatment unless you've got the diagnosis right. So it's a marvellous thing that Leukaemia CARE is trying to publicise these sort of basic things. Now, to function, Leukaemia CARE's got a very small team of dedicated staff, but masses of voluntary people who assist by answering the telephone out of hours. And if you want to talk to somebody, it may well be the middle of the night that you want to talk to somebody. So there is somebody available, which is absolutely super. But as well as that, the Leukaemia CARE produces booklets and information. And I just picked up one of the step-by-step booklets, and it's really help for carers, not help for the patient, but help for the carers of patients, and they certainly need help as well. So it really is a marvellous charity. Now, I've got to mention Peter Ives somewhere, a founder member of Leukaemia CARE. Absolutely wonderful of you to come and to have started this absolutely wonderful charity. And on a less happy note, I'm told that Tessa Olioke, a key chronic myeloid leukemia researcher, passed away in Glasgow actually yesterday. So that is very sad, and obviously we thank her for all that she did. And the person who is missing today, I'm afraid, is Ian Gibson, who was my predecessor as chairman of this, and I got to know Ian very well when he was when I was an MP and he was an MP, and he was what I called one of the thinking Labour rebels. And those are the right sort of people you want. The people who aren't just going to follow a whip, they're going to do what they know to be right, and what they know the people they represent want them to do. So thank you very much, everybody, for coming. It's marvellous to launch this Spot the Diagnosis campaign, and somewhere the 6 vital points are before you, and take those home and tell your GP about them and make sure he knows about them, because that's where the diagnosis has got to start. So thank you very much.
Hello, so I'm Zack from Pemberton-Whiteley. I'm Head of Campaigns and Advocacy at Leukaemia CARE. We're going to start by presenting the findings from our Living with Leukaemia survey report.
Hello everyone, my name is Jennie Bradley and I was the project manager on behalf of Quality Health for the Living with Leukaemia survey.
So the project was designed as a follow-up to the NHS England's annual Cancer Patient Experience Survey, because we'd identified a number of issues experienced by leukemia patients that weren't covered in the CPES survey. Our intention was to identify and quantify patients' experience of these issues, and then use them to refine and improve leukemia care services, but also to campaign for external improvements where patients were telling us they were needed.
The survey was actually carried out using 2 distinct arms of patients, so 2 different groups of patients. The first arm used leukemia patients who'd taken part in the 2015 National Cancer Patient Experience Survey, and they had given specific permission to be contacted to take part in future research. The second arm was actually an anonymous cohort of patients. It was an online survey of the wider blood cancer community. And this was publicised through various online and print channels with our partner charities. Through exploring these 2 distinct cohorts, the survey sought to identify areas where leukemia patients reach out to charities for support, and also to identify those areas that patients need support but currently have nowhere to reach out to. So, in terms of the format of the questionnaire, we followed the tested format similar to that used in the Cancer Patient Experience Survey and national patient surveys that are carried out, and that's sort of the patient journey through the care pathway. So there were many questions that came under these broad topics following that pathway, from before diagnosis, through treatment, and to after treatment. And interestingly, Leukaemia CARE also wanted to add sort of 2 different areas, which was living with blood cancers, which is very sort of important and relevant to leukemia patients, and also patients' views on potential new treatments. So the questionnaire was developed and designed over a number of months in 2016, following detailed discussions between Leukaemia CARE and Quality Health. We took many considerations into account, including sort of wording, understanding of the questions, and really what the aim of the questions were that we wanted to find the answers for. Importantly, the questionnaire was tested by 9 patient volunteers. It's a really, really valuable exercise. This contributed towards refining the questionnaire into the final version. We spoke to patients, asked them to complete it, and then we had some discussions with them to see what was working, were questions too invasive, and checking it was all understandable. And all this was fed back into the final product. There were 2 versions of the questionnaire, and that was simply because for Arm 2, the anonymous cohort, we just wanted to collect 8 additional pieces of information that we already knew from the CPES cohort. So response rates, this is something we're very, very pleased about. You can see here that the number of leukemia respondents were 1,320 from that CPES cohort and 699 from the anonymous, so giving us 2,019 in total. When we look at the response rate for the cohort from the CPES, it was 78%. That's excellent. I mean, to give you some context, the National Cancer Patient Experience Survey has a response rate of 66%. So this tells us leukemia patients want to be engaged with the process and give their feedback, but also it gives us that lovely robust data set that you can drill down into and rely upon. You can see here as well, we've got the breakdown of the different subtypes of leukemia and the number of respondents that we had in each.
So in terms of the demographics of the respondents, we had a higher proportion of male respondents in the survey, as you would expect that correlates with the higher incidence of leukemia in men. But interestingly, we had a higher respondent rate from females in the anonymous charity group. That suggests that females were more likely to reach out to charities for support. In terms of age, we also identified a series of age-related issues, and we presented findings of these separately in a report called I Wasn't Born Yesterday, which you can find on our website. Before we go through some of the specific findings from our survey, I just wanted to take the opportunity to thank all of the other blood cancer charities who helped us promote the survey to their members and encourage such a good response rate. So one of the first key findings was about the emotional impact of leukemia. So this was something we already were well aware of, but we wanted to investigate further and quantify some of the issues. It's a key issue that's often missed or underestimated, whether that's an acute patient dealing with the emergency nature of a diagnosis or a chronic leukemia patient living with it over a period of time, perhaps.
We're able to look into more of the issues around emotional impact by cross-referencing different questions. Our research has shown that relapse has a clear impact on emotional well-being. But disappointingly, only 16% of patients said they were offered counselling or psychotherapy, with chronic patients much less likely to say they were offered it in comparison to their acute counterparts.
Based on this, we've made a recommendation that there is a better need for support and signposting, and in particular, we're looking at the periods during watch and wait or when a patient has experienced a relapse. As everybody knows, internet usage is on the rise amongst all different age groups, and as a result of it, this websites have become a key source of leukemia information. It's important that the information patients are accessing is both accurate and up to date.
Our survey revealed that 2/3 of patients weren't told anything about the internet by their health professional. But despite this, 61% still went on to use it to try and find further information. But again, through cross-referencing questions, we were able to find out that those who had actually spoken with their health professionals, had been advised to look at trusted websites, were actually more likely to find the information that they found useful and helpful.
As a result of this, we've recommended that all healthcare professionals should give guidance to their patients on using the information, using the internet to find verified information online. One of the next key issues was watch and wait for CLL. We frequently hear from CLL patients about various issues with living with watch and wait, and we've already mentioned the huge emotional impact this can have, but we also wanted to look at a number of other topics.
Over 3/4 of the CLL patients that we spoke to said they had been placed on watch and wait at some point. And while the majority of people said they understood the reasons for being placed on watch and wait, over half still had concerns and worries about this. And looking at sort of written information, which is a very important key point, of those who wanted written information about watch and wait, while 56% of it were given it and found it to be understandable, there was still 1/3 who were not given any written information. And there was actually a further 8% who were given information but did actually find it difficult to understand. And again, looking into those results, cross-referencing, they show a direct correlation between the amount of written information a patient is given, how easy it is to understand, and then how worried a patient actually feels.
So based on these findings, again, we've recommended that all patients diagnosed with CLL who are placed on watch and wait should be given written information at this point, along with a full and understandable explanation of what watch and wait is. One of our other recommendations relates to clinical nurse specialists. Clinical nurse specialists are widely accepted as one of the most positive influences on the patient experience pathway, but our findings suggest that leukemia patients have issues accessing them.
Interestingly enough, our survey findings challenged the data that was available for the provision of clinical nurse specialists for leukemia patients. So in the Cancer Patient Experience Survey 2015, 85% of patients said they'd been given the name of a CNS, but on average, only 38% of the people we surveyed said this was the case. And this was even lower for those with a chronic leukemia and those on watch and wait.
Again, we've made the recommendation that all patients should be able to access a CNS, and this should include CLL patients on watch and wait, not just those who are on treatment. One of the key findings that is worth mentioning is the differences that spring up throughout the report in terms of the different leukemia types and the need for tailored support for each of these different groups.
The most pronounced differences, as you would expect, are between acute leukemia and chronic leukemia patients. And there's probably too many to list individually, but for example, some of the key points were differences in route to diagnosis, those who accompanied to the diagnosis meeting, the impact that leukemia had on work or education for these patients, provision of additional support, and as we have already mentioned, the clinical nurse specialists.
As a result, we have recommended that all of the information provided to leukemia patients should be as tailored as possible so that it meets the specific needs of their situation. And the next three recommendations are some of the key ones that we're picking up at the moment. These are the three recommendations that have informed our Spot Leukaemia campaign.
So leukemia as a term is well known. 83% of patients reported that they'd heard of it before their diagnosis. But then when we sort of asked further questions, it became apparent there's little public understanding of leukemia, with only 1/3 of these patients reporting that they really actually knew anything more detailed about it.
As a result, for our Spot Leukaemia campaign, this time we've gone beyond the traditional awareness of Blood Cancer Awareness Month and decided that instead we should be calling for a greater knowledge and public understanding of actually what leukemia is. And hopefully you'll see that's reflected in the campaign.
So despite most patients experiencing some sort of symptoms before their diagnosis, very few people actually expected or suspected that they may have cancer. So this is suggesting that people are not aware of the symptoms that could indicate potential leukemia. In fact, 44% of acute leukemia patients and 66% of chronic leukemia patients said they waited more than a month before going to see their GP.
As a result of this finding, spotting the symptoms has become a real key theme of our campaign, which I'll talk about a little bit more in a minute.
And our results also show that there are big differences between the 4 main types of leukemia and then that reported route to diagnosis. Our results show that emergency presentation overall continues to be the most common route for patients. On average, 1 in 5 leukemia patients said they visited their GP more than 3 times before they were referred to hospital. And overall, 13% were initially treated by their GP for another condition. And then less than half of respondents felt their GP had a complete understanding of blood cancers.
So as a result of these findings, the element of increasing awareness and understanding amongst healthcare professionals such as GPs has become a key part of our campaign and also our wider work at Leukaemia CARE. So before you all leave tonight, you can pick up a copy of the executive summary of the report, and the full report is available to download on our website at the following link. I'm now briefly going to mention some of our Spot Leukaemia campaign, which we're also launching today. The campaign is the first step of numerous different projects we have planned to address the findings of our Living with Leukemia report. So as hopefully all of you know, September is Blood Cancer Awareness Month, and this September, Leukaemia CARE are asking the public to turn spotty and encouraging them to spot the symptoms of leukemia. We're aiming to both improve public understanding of what leukemia is, but also hopefully to reduce the emergency presentation rates, which are much higher for leukemia than for other types of cancers. So leukemia is particularly hard to spot because it's quite a rare condition, and although there are numerous different symptoms that are experienced by patients before they're diagnosed, they're non-specific. There's no one key symptom that we attribute to leukemia that not to anything else. So what we're aiming to do is to get the public to spot these clusters of symptoms and to seek medical attention if they are worried. So we've worked with Brandcast Health, who very kindly helped us produce this graphic to help raise awareness of the different symptoms of leukemia. If you want to access this video, share it online. That is a key part of our campaign. All of the work we've been doing has been informed by the findings from our Living with Leukemia survey. So as well as the video, we've also developed symptoms cards, which have been targeted to different age groups based on the different types of leukemia that are more common in these age groups, but also the symptoms these different age groups experience before they're diagnosed. For BCAN, we'll also be turning everything at leukemia spotty. So we will be doing spotty support groups, spotty conferences, spotty awareness events, hopefully spotty social media. We've launched an online social media campaign this September, and if you want to find out more about that, use the hashtag Spot Leukemia. In particular, we've got a thunderclap which will be going out on the 13th of September. It's already reached over 850,000 people, so please do join that and help us reach as many people as you possibly can. As I mentioned, GPs as well as public are also a key focus of the campaign. So we've been sending out 10,000 packs to GPs throughout August and September to make them aware of the Spot Leukemia campaign. So the last key message is, why is all of this important? Quite simply, awareness and early diagnosis saves lives. So if you want to find out more about the campaign, visit our website and hopefully get involved in the work that we're doing. I've got nothing else to say, so everyone, please just talk to each other and enjoy the wine and have a good Friday evening.
Hi everybody, I'm Nigel Deekes. I've been asked to speak about being diagnosed with leukemia. Cancer and leukemia, they're very big, very strong, very emotive words. As a member of the public, you don't really understand them. We all hear that patients or people will generally have a percentage chance of getting a cancer of a third, moving up to 50% these days. But like everyone, you don't really think it's going to be yourself. My diagnosis of leukemia came about just coming up 6 years ago. This month, I didn't have what I thought was any signs of being ill. I worked full time. I played squash 3 to 4 times a week and felt very, very well. I've been losing weight, but put that down to squash. Everyone puts things down to different things. And if anything, I actually found it quite a bonus in my naivety, because I was getting to the point where I could eat anything, could do anything, and just keep moving forward. I was having some terrible night sweats, but again, it's summer, so you sort of put it down to that. I've been having some trouble with my spleen, as it turns out, but again, you don't realise that at the time. So that's all the things that have been said a minute ago. We as members of the public don't actually know, generally speaking, the symptoms of the illness, and that's why the campaign that's being run at the moment is so critical, really, to getting the message across to doctors, to the general public, really. So my diagnosis, I basically 20 years ago had a detached retina. I'd been suffering over the course of a weekend with some flashing in my eye, and so really put that down to a problem with my eyes and assumed I'd got a detached retina. Took myself up to the hospital on Sunday night, was there for 3 or 4 hours, had various tests done, and then on the way out had what I felt was a very cursory blood test. It really was just, oh, we'll just do this on the way out sort of thing. So I got home about 9:30, 10, put my mobile phone on the side, went to bed and really didn't think anything much of it. Next day was the National Squash Championships up in Manchester. I was going up with a group of friends. So that was my day planned. Woke up the following morning, picked up my phone, got 4 messages from the hospital saying, phone us first thing, as soon as we open. So I rang them. Department didn't open till 8 o'clock. 7:15, I get the phone call saying, get up to the hospital. We've got an appointment for you at 9 o'clock. Again, I didn't really think much of it. I mean, go to the haematology. I've got a bad eye. Yeah, I'll go to haematology, that's all right. So I was sort of saying to everyone, I'll meet you up in Manchester, lads, don't worry about it. So I get to haematology department, first person in, sat down, doctor gives me the news. Doctor was absolutely fantastic, I have to say, brilliant. Spent the best part of an hour with me. There was a nurse in there, told me all about my illness, told me about the prognosis, which seemed unbelievable. I should say I've got chronic myeloid leukemia, which there are very good drugs for. So I spent about an hour in there. I was on my own, obviously shocked by the diagnosis that I'd had, but I'm quite a matter-of-fact person. And so it was, right, tell me what I've got, tell me what we're going to do about it, how we're going to get it sorted. So I finished that, I came out, and one of my abiding memories of walking out of that waiting room was seeing a row of people sitting there thinking, God, he's been in there a long time. And I have to say, great for the doctor to be able to give me that time, that care, is a fantastic thing to have had. So, as I say, I'm here really to talk about my diagnosis. So, obviously, I'm very upset. I go home, I phone my wife and say, you need to come home, need to see you, sort of thing. So again, she comes out of work, sees me, walks in the lounge, I give her the news. Self-evidently, your world's falling apart. You're very, very upset by what's going on. We made the decision, actually that's not true because there wasn't a decision to be made, but to tell our children straight away. Kids were 12 and 15. It never occurred to me not to tell them, whereas I know a lot of people don't pass this news on and everyone to their own. Children were very, very upset, obviously, ran off in tears, etc., etc. My overriding memories of the diagnosis, and you touched on it a moment ago, were several things. First of all, I was given a booklet which told me about this new wonder drug that had just recently come out. The booklet, I think, was 2006. I was now 2011. The booklet was talking about this drug. It was having some impact and things were looking quite rosy. So you think to yourself, well, hold on, my doctor's telling me one thing, I'm being given a booklet which is telling me something completely different. So again, the message has got to get out there correct. That's the first thing I'm really trying to say. Second thing, clinical nurse. I had a clinical nurse given to me at diagnosis. Again, she sat with me in my hour where I was in there. Very good. Next day, I went back and saw the nurse with my wife because obviously she didn't know what was going on and we wanted to find out more about chronic myeloid leukemia and whether or not all the good news I was being given was true. From that point on, I had absolutely nothing to do with the clinical nurse. Really didn't at all. You'd go to clinic, there would be lots of patients there, a few nurses floating about, but no one that you could ever really talk to. You didn't feel as though you could approach these people because actually I'm not very ill. Chronic myeloid leukemia, you take your pill and you're okay. And I think that's something that needs to be worked on a little bit, shall we say. So we see the nurse, I'm given my drugs, I then have to learn a new language. Chronic, acute. Now to me, chronic was awful. Chronic was far, far worse than acute. And again, as a layman out there, I just wonder how many other people actually don't have that understanding of what those terms actually mean to us and have the time for it to be given to us, that information. Again, talked about social media a minute ago. I made the decision not social media, sorry, the internet. I made the decision not to search the internet because my experience of the internet, and certainly within the occupation I have, is that people only ever go on the internet to say, this is awful, that's terrible, I'm really well. People don't go on the internet and say, actually, that was a great experience. So I avoided that. I then, however, because I couldn't quite believe that I was going to be so well on this wonder drug imatinib, made the decision to actually search the web. That's when I came across Leukaemia CARE. And I have to say, Tony, who was a great friend and help to me through my diagnosis in the early days. And I also have to say, at the back of the room, Sandy Crane isn't here from CML Support, but again was a great help to myself. And so these organisations, be they Leukaemia CARE, be they CML Support Group, be it other charities out there, are invaluable to us. Where am I now? 6 years down the line. I had a go at stopping treatment about 18 months ago because you can now, for certain patients, get to the point where you can actually stop taking your drug. For me, it didn't work. I didn't fail because I'm still very well, and people have this perception that you fail and, you're going to be, are you going to die? You're going to do this, that, and the other. So for me, my next step is to try again in a year or two. I'm one of the very lucky people that my drug suits me. I have absolutely no side effects. I work full time. I still play squash. I do everything that I did before. So the journey for some of us leukemia patients is very, very good. And generally speaking, things have come on a long way. However, I also have a nephew who, a year after I was diagnosed with AML, 4 years old. His journey has been so unbelievably different to mine, as I'm sure you will all know here. It's fundamentally a different illness. And again, we hear the term leukemia, and we being the general public, group everything into one. We don't have the understanding of what these different illnesses are, and the message is to get that out there to people. So, I'll finish with 2 or 3 things. First of all, my nephew is very well. He's finished his treatment. Some side effects, some issues, but 4 years on, he's doing very well. 6 years on, I'm doing very well. Without my drug, I wouldn't be here, full stop. And the reality is I am here. I'm able to talk to you and thank everyone for all that you've done for us, the doctors, the drugs companies, the NHS. I will say one other thing on the NHS as well. I came out of the NHS at diagnosis and I went to Bupa. And to me, that was the biggest mistake I made in my treatment. I really would say that. So God bless the NHS and everything you do for us.
I'm Mary Frances McMullin. I'm a haematologist, and I was asked to say a few words about this from a clinician's point of view. So I have been looking after patients with leukemia for over 30 years. Leukemia is a cancer of the blood, but it is the dreaded word leukemia that everybody knows, and I think we all appreciate that it's widely known. But leukemia is not a single disease, but comes, as we've heard, in various forms, acute and chronic, lymphoid and myeloid, depending on the type of cell which is involved. However, it is actually, from our point of view, much more complex than that, because even within a single type, some patients have a disease which seems to come on very quickly, with no warning. Often, even when I see them, they've had very little in the line of signs and symptoms, whereas others have a much longer lead-in. Again, when we see patients, they can tell you the sort of signs and symptoms they've been having for considerable periods of time. And this, of course, is because it's not a single disease, but a wide spectrum of disorders, which we do not really understand all the differences, but that's what is there that we have to cope with. And of course, and I think this is an important point, outside my world, and unfortunately many of your worlds, these are actually very rare diseases and very rare for the general public. As you have heard, the presenting signs and symptoms are very variable and can be very difficult to assess. We've heard a lot about trying to get the symptoms together, but there are certain signs and symptoms that may be a clue. Tiredness is often mentioned, but lots of people are tired. Somebody recently said to me tiredness was the 21st century disease, but this is different tiredness, and it's trying to pick up those people who maybe weren't complaining of tiredness and now are suddenly profoundly tired. Night sweats are another thing that have got in the popular press, and it's hot in the summer and people get night sweats and things like that. But again, it's the change, it's suddenly developing night sweats. And I'm only picking on a few. And then the big one from my point of view is bruising or small bleeds or spots. We call them petechiae, they're little bleeds into the skin, but the spots are important. Any of these and any combination of them makes you think about spotting the diagnosis of leukemia. And as soon as it's thought of, what we want is a blood test. A blood test can be undertaken rapidly if there is any suspicion in order to spot the diagnosis. And they're freely available throughout the NHS with results within less than 24 hours. I have to say, leukemia is actually not a particularly subtle diagnosis. It's not something about being slightly wrong and you missing it. Usually the blood test is very abnormal when it's done, and it's then easy to spot the abnormality and go from there to make the diagnosis. The earlier the diagnosis is made, the earlier treatment can be initiated. And while I've made the point about the disease being very variable, and particularly the rate of progression, the longer the disease goes undiagnosed, the greater the burden of disease at the time the person comes for treatment, and that is very important. Also, the sooner treatment is started, the less the time there is to develop the other complications that come with the failing bone marrow that goes with the treatment. and in fact, development of complications may interfere with treatment and may worsen the ultimate outcome. So the sooner you get to the diagnosis, the quicker treatment can start. As haematologists, we actually look after the haematology laboratory as well as the patients. And when we see abnormal or suspicious blood counts, we will intervene and find the patients. Often, depending on the blood count and the circumstances, we will admit patients immediately to hospital. Doesn't matter if it's an emergency. If the count deserves it, they come that day. And that can be people who have had a very short period of being unwell. Acute leukemia particularly needs to be diagnosed and as soon as possible to initiate treatment. However, I would make the point about the other types of leukemia that it may be different. Definitely some of the chronic leukemias, it's a different story. Chronic myeloid leukemia, as we have heard extremely eloquently, is now, as far as I'm concerned, treated as an outpatient with a tablet, and while the sooner the diagnosis is made, the less the burden of the disease. Most of these patients now with oral life expectancy have actually a normal life expectancy compared to their peers. And that's a huge change that has come about in the last few years. And we've heard a lot about chronic lymphocytic leukemia, which is also very variable, and in particular the fact that many of these patients are in watch and wait. And as more people are diagnosed earlier, there will be more people falling into that category. And that's actually good from the patient point of view, but obviously it's very challenging when you start with the leukemia word and perhaps don't get beyond that. But it's actually very important from a patient point of view that they're on watch and wait. So in summary, therefore, it is very important for everybody to be aware of the signs and symptoms that might suggest a diagnosis of leukemia, to spot the diagnosis so that the freely available blood count can be done as soon as possible in order to make the diagnosis and institute the appropriate treatment. Thank you.
So finally, just thank you to all of our speakers and also everyone for coming. Last thing, don't forget to collect a copy of the report and the bag that it comes in on your way out. Thank you.